So, thank you very much for the opportunity to come and speak to you today. My name is Goodden. I'm a consultant neurosurgeon in Leeds. I've been there for 11 and a half years now. Wow, time flies. So, what I wanted to do was start with a little bit of a background of who I am and a little bit of a background about paediatric neurosurgery in Leeds, and then a couple of insights into a couple of the things that we do. Selective dorsal rhizotomy, which is a service that I started in Leeds back in 2012, and also an overview of how we treat brain and spine tumours and the interaction with technology and the importance of technology in that as well. And that also then ties into the next bit of just showing how the technology has advanced over the years, and then also some pointers towards the future in the new children's hospital. What are the sort of things we need from a neurosurgical standpoint, and actually what are some general thoughts in terms of vision for the new children's hospital. So I was born and bred in Dorset, in the middle of the country, on a butterfly farm, and raising caterpillars and moths and butterflies. Great way to grow up. And then went off to med school in London. Tooting is a very far cry from Dorset. And then my neurosurgery training down in London, and then drifting further and further north, Sheffield and Hull, and then a specialist fellowship in Alderhay, and also did stints in Paris in the children's hospital over there, and also time learning selective dorsal rhizotomy in St. Louis in America as well, in Missouri. So as a consultant neurosurgeon, I've got an adult and paediatric mixed practice. Technically 50-50, I think it's actually 70-70 or something like that in real life. A large focus on brain tumour treatment, but also the spasticity management, particularly with children, and other things like hydrocephalus, which is water on the brain, and obviously trauma and other things related to that. I'm a medical trustee for Candlelighters, and I've got some charity involvement with Calderwell Children's, where they're involved with spasticity treatments as well, and so I've been helping them with aspects of selective dorsal rhizotomy and spasticity treatments related to that. I'm married, 2 daughters, 18 and 20. I can't quite believe they're that old. It still feels like they were only that high a very short time ago. And I do have some outside interests. I'm an active member of my local church, and I like Formula One and photography as well. And that's the British Grand Prix a couple of years ago, but I might be trying to pay Sebastian Vettel to do the same later on in the next race, maybe. We'll see. So, paediatric neurosurgery in Leeds. We've got a catchment population of about 3.4 million. We are one of the largest centres providing paediatric neurosurgery within the UK. I think we're probably about the 5th largest in terms of our operating capacity and our catchment area population. Obviously, centres like Great Ormond Street, we can't rival in terms of our catchment because we haven't got a centre like London around us. But we do have a comprehensive delivery of subspecialist expertise. And this has been one of the things within neurosurgery where neurosurgery has been a leader throughout the time within medicine of developing areas of subspecialist practice where we build our expertise. That means we can do what we do better and safer as we go through. So we look after children with tumours, brain and spine tumours, craniofacial surgery, skull deformity problems, spasticity surgery. I'll tell you a bit more about that in a minute, but selective dorsal rhizotomy and medicine pumps in the spine to help control the stiffness in the legs. Dysraphism is a term for children with like spina bifida and associated disorders. Hydrocephalus, an excess of fluid in and around the brain, and blood vessel problems. And again, that's something that's fairly unique to Leeds. Not many other centres have got the same degree of expertise as we have in that. Atul Tyagi leads that service, and he's got a very specialist expertise because he does the same sort of treatment in adults as well as in children. But these problems are very rare in children, so the fact we've got someone with dual expertise in that is very helpful. So that's who we are, little pictures to put faces to the names. The 4 of us running the service with a busy on-call rota, hoping at some point to expand to 5. We've got a very good, dedicated paediatric neuroscience ward. So we deliver joint care with the paediatric neurologists, but we've also got a very significant multidisciplinary interplay with the other specialties that we work with, and we work across the board. So we will need input from orthopaedics, seen Colin there, sat there in the corner, from ophthalmology, from maxillofacial surgery, and from plastic surgery for the craniofacial work. There's a lot of different areas that we work across. Of course, paediatric oncology for all of our brain tumour children. So we need that interdependency, and also with the rehab services and allied health professionals, and a very good specialist theatre team with a very well-equipped theatre, which you'll see a picture of later on, and a close-knit team of theatre staff who are very, very good at what they do in supporting us, helping us to do the work that we do as surgeons. So, selective dorsal rhizotomy. This is an operation that was first described a little over 100 years ago in a cat model of cerebral palsy. And what the procedure involves is cutting about 2/3 of the sensory nerve roots in the lower back. And it's obviously a very delicate procedure and has a great potential to go horribly wrong if you do the wrong thing, because mixed in with the sensory nerves are the movement nerves. So if I start cutting movement nerves, I'm causing paralysis. So getting it right, getting it perfect every time has got to be the aim of the surgery all the way through. And the whole principle about this is for children with cerebral palsy. So normally when they're ambulant, they're up on their tiptoes and their legs are crossing over, they're often tripping over, their legs are quite stiff so it's hard to move as well. And what SDR does is it takes away that stiffness. Now it unmasks the underlying weakness that they've got, so they need a lot of rehabilitation afterwards, and they are literally relearning how to walk. But the effects for the children are massive. We're only one of 5 centres delivering this within the UK. I went over to the States in 2010 to learn how to do it. We did our first operation in 2012. We've now done 147 as a team now. I've been the surgeon for all of them, but I refer to us as a team because patient selection, rehab, all of that, doesn't matter what I do, if I haven't got the team around me, then we're not going to get the successes that we get. What the screen is meant to illustrate in the top corner here, if I can move that, is we have the tip of the spinal cord here and the sensory nerve roots on either side. I separate the sensory nerve roots into a sling and then have to separate off a portion of that sensory nerve, and we've run a bit of electric current through there to basically stimulate the nerve and see how active that nerve root is. Having done that stimulus for one nerve root, I then do it for another portion of the nerve root and another portion of the nerve root, and the 2 most active ones are the ones that get cut. And if that video was running, which it's not unfortunately, you would see a little demonstration of what the surgery involves, of basically doing that dissection and then coming in with a pair of micro scissors and chopping. And once it's cut, that's not coming back together. So if I don't get that right, if I've cut the wrong nerve, that's not coming back together, and that's irreversible. And this is where the technology for like the operating microscope, the ultrasound during theatre, these are things that I rely on absolutely heavily to make sure that I do the operation successfully and do it well. And then after the surgery, they're having 3 weeks of intensive physiotherapy. And so the treadmill you can see here is about £25,000 worth of specialist treadmill equipment that's got different height adjustments for the different children. It's also got access for a hoist. That was something that the charitable foundation, that the charitable trust funded. There was a donor that said, is there something you need? And the physio said, yes, we need this treadmill. And that was bought about 10 years ago now. And we've had massive, really, really good use out of it. And then even more simple equipment like the bars and the mats. Well, the mats wear out really quickly. But the gym environment is something that is well equipped, well appointed because of the work that's been put into appointing it. But we need all of that to get the best output for the children to help their recovery after the surgery. And it's not just a physio. Some of the children have got some degree of learning disability as well and may need some play therapy input as well. And then also gait analysis is a really important part because understanding how the children walk before their surgery, after the surgery, monitoring the change over time, helps us understand more about what we do. And at the moment, the children are having to go across to Chapel Allerton Hospital to have that gait analysis, and go there, come back, and have multiple appointments on different sites. What we see with all the children is a reduction in spasticity. So the stiffness they've got in their legs is either reduced very significantly or absent. It's absent for about 90% of the children that we've treated, and it's very much reduced for the others. That gives them better comfort, better ease of movement. They can participate in things more easily. Better function, better quality of life, and there's a quality of life assessment tool that we've been using and that we've published recently, showing the statistically significant improvement in quality of life as a result of this surgery. And most importantly, no significant complications. And then other things which are quite difficult to measure, and this is where our physios have called them the little big things. One of the things that's on there, like being able to walk holding one parent's hand, rather than holding your frame, being able to walk with your hand up, holding mummy or daddy's hand, makes a huge difference. So many of these little kids, you pick them up and they're like stiff as a board. You try and put them on your hip to carry them. You can't, because they're just stiff as a board. But with the relaxation from the surgery, pick them up, pop them on the hip, walk along, and so these mums are saying, I just did that automatically and it happened, and wow, that's just, it's quite a hard thing to measure, but it's made a huge difference to quality of life and normality for that family. And things like being able to stand, being able to balance while you brush your teeth, or if you're a little boy, being able to balance without holding onto things so you can have a pee, standing up like other little boys of your age. These very normal things that we take for granted are difficult to measure, but can make quite a big difference to the quality of life for the child. This is a little girl who was about 3.5 at the time of her surgery. This is her walking before her surgery. And you can see how she's dragging her feet. The amount of movement in her legs is relatively restricted as she goes forward. And then this is her 12 months after surgery. So her speed of walking has gone down, but now she's using sticks. She's not needing her frame anymore. So she's already gained some degree of independence from where she was. And then this is her at 2 years post-op. And you can see the difference in how easy it is for her to move her legs, her strength, her core abilities. And she loved this improvement that she had. And you get a little demonstration of that in a second. One of the things she wanted to do before the surgery was be able to jump, and we were really hesitant on that in terms of just didn't want to set the expectations too high. So before the surgery, she wanted to improve the ability to use her frame, possibly move to sticks. A bit of a pipe dream was walking independently. Well, you've just seen on the video, yes, she did that. So the improved exercise tolerance, reduced nighttime waking. If you sleep better overnight, you're better rested in the morning. You can concentrate better at school, these sort of things. So she set those goals. She surpassed those goals really quickly. This is another lass who's 6.5. You can see how she's dragging her feet. She would wear through a pair of those shoes every month. Every 4 weeks she would wear through those shoes. And this is her 5 years post her SDR surgery. So I've shown you two videos out of a selection. We've got loads of different patients. These are some of the more mobile children. There are other children who are still needing sticks and walking aids. It doesn't mean that we get rid of them altogether, but it does make a massive difference. Moving on to something completely different, the brain and spine tumours. That's a picture that all of you may be familiar with, of the lovely new building that we've got. A wide variety of tumours in a wide variety of sites. Front of the brain, back of the brain, in the spinal cord as well. These things are often quite big. So this is a tumour here. Made a mistake of pressing the screen. So there to there is tumour. So almost filling half that child's head. And when we're operating on things like this, we need a great team around us knowing what they do, but we also need the access to technology, things like neuronavigation, access to MRI scanning to help us see where we're up to, see what we're doing. Whole list of different diagnoses on the screen there. Neurosurgery, surgery to resect tumours, are needed for just about every brain and spine tumour that we come across. The only exception there is biopsies of the brainstem. Well, because the brainstem does heart rate and breathing control, we're not going to be able to take out a tumour from the middle of the brainstem. So those are just a biopsy. But for everything else at the moment, surgery is the mainstay of the first line of treatment for these tumours before they then go on to other oncology treatments. So we need to do what we do to the best of our ability, and we need to get it right, and we need to be safe at what we do. So these tumours are a challenge because of where they are, and because of their size, and because the brain is not forgiving. When a nerve cell is dead, it stays dead. So if we cut out the wrong thing, if we cut out a bit of brain that we shouldn't have cut out, we can leave that child with a weakness, with a paralysis that is there for the rest of their life. And with this, we need that whole multidisciplinary team input and the planning. And we've got to have the right skill set, we've got to have the right equipment to let us do what we need to do and minimise the risk with that surgery. Neurosurgery is fundamentally dangerous, but we can make it safer. And this is the intraoperative MRI scanner. So the transfer table, can't work a mouse backwards. So transfer table here that then docks with the scanner, and so we can operate on a patient, we can then keep the surgical area sterile, put additional coverings around it, including the magnet coils, slide through, do a scan, see how much of the tumour is left, where is that last little bit. And that is vital because when we're talking about the outcome, the extent of resection is one of the key differentiators between survival and not survival, or length of survival for these children. So if we leave a little bit behind, we may well find ourselves having to go back to get that last little bit. So if we can do the scan during the surgery, then we save them a whole extra trip to theatre. And going through doing the scan, coming back, taking off the drapes and going back straight to that point is really quick and easy if we do it, well, relatively easy, if we do it at the time when we're doing the surgery first off. If we've got to go back another time, then you've got to put them through that whole process again. So with our surgery, it's about the right surgery, the right equipment, the right timing, and then the right rehab and the right oncology care, which is all very specialist afterwards. Neurosurgery has been a specialty which has insisted on technology to guide the excellence of what we do. And it has been something that has led a lot of other areas. The first CT scanner on that picture, that was built as the EMI scanner at Atkinson Morley. It's now in the Science Museum in the early 70s. Now, there's our MRI scanner. We use navigation as a routine for what we do. It is a key part of what makes what we do safer. Now, if you go in as an adult to have a knee replacement, you will have that knee replacement used with navigation to make that safer. 20 years ago, when I was a medical student, it was just various guides that looked like carpentry guides. It wasn't navigation. Flint knives, steel knives, beautiful things in a lovely, lovely velvet-lined box. Now we've got high precision instruments, and they're our Neurosurgical advanced stereotactic robot that we've just been doing some more training on today. These tools are ever increasing in their complexity. The complexity of what we do increases, but there are tools out there to help us do what we do more safely. And obviously, theatres have come on some way as well. And that's our current neurosurgical theatre with inbuilt navigation system and screens so that we can have our imaging displayed, our advanced digital microscope that's even incorporates robotic technology for the motors to move the arms. So all these things are things that we are very much reliant on. But of course they also have a shelf life. So by the time we've got the new Children's Hospital built, the microscope will be portable, The navigation system will be actually towards the end of its life by that stage, because it's already will be reaching 7-8 years old by that stage. So the things will be actually time expired in terms of the technology and survival. So what are some future priorities? We've got great teams. We've got a lot of people with a lot of specialist expertise, but we also need to be able to attract and retain staff moving forward. And we need to invest to make sure that we've got the right equipment, the right facilities and the right environment. From an equipment point of view, things like the intraoperative MRI will have to be re-provided in the new hospital. Again, that beautiful magnet we've got now will be 8-10-year-old technology by the time the new children's hospital is commissioned. That will be essentially obsolete equipment by that stage. It will be old. Same for navigation. Endoscopes, we've got ongoing discussion, we're trying to replace our endoscopes at the moment. The ward environment and rehabilitation equipment, all these things wear out and need replacement. And then other things in terms of facilities. At the moment, Gate Lab is over at Chapel Allerton Hospital, and we have to send children over there for it and bring them back. Our orthopaedic surgeons are sending patients down to Sheffield for some of their gait analysis. There's an opportunity for us to have gait analysis built into the new children's hospital. Hydrotherapy, we're currently very much reliant on hydrotherapy for our rehab program for our spasticity patients, but also brain injured patients from trauma, from the brain tumours. And actually, some of the community teams are also renting out space in our hydro pool as well, because there isn't access to any other hydrotherapy service within Leeds as well. So the hydrotherapy pool, the equipment for the physio gym, these are all things that are really important. But then the built environment is also a critical thing. Staff need places that they can rest, that allows them to de-stress, and that's something that helps us with the staff retention. But also, this is a children's hospital, so kids are going to be stressed. We need things that can be fun, that can be nice for them. I read stuff about Medicinema. I read stuff about things that are nice leisure things for children to do whilst in hospital. And we've got to have stuff that allows them to do that as well, allows them to be children rather than objects being treated. And same for parental accommodation. If you've got to walk half a mile back to your room and your kid is on ICU, having just had a neurosurgical operation, do you really want to do that? Or can we have rooms that are close enough that allows the parents to be in touch but also get the rest that they need to do while their kid's in critical care, having their treatment? Things like that are things we need to think about, how we can accommodate that for the families. So I think this is my summary, that the new children's hospital is our opportunity to create a world-class hospital that is centred around the child and allows us to deliver the excellent care that we are called to provide. And a little thank you slide with some of our SDR patients that have given permission to have pictures on a slide, because they are the centre of what we do. So, any questions? Thank you very much.